Kristin, thanks so much for having us.
Well, thank you so much for inviting me. This is wonderful.
I think, first of all, people would appreciate knowing who was Lee McCullough and how did you come to know her?
Well, wonderful question. I mean, Lee McCullough was a researcher and psychologist at Harvard Medical School, and she was very much invested in discovering like what works in psychotherapy. And so, in her, I guess, research travels, she began to pick up like what she thought was really essential to psychotherapy and develop the model affect phobia therapy.
Mm-hmm.
And she's written two books. Changing Character was her first book in 1997, and it's an absolutely fabulous book. Really in depth, lots of case studies.
Mm-hmm.
And then her next book, manual, treating affect phobia therapy, which she wrote with her colleagues in the Boston area.
Yeah.
And so, Lee McCullough introduced me to experiential psychodynamic work. And I started working with her in probably 2003. And how that started was through her research group. So I was a member of her research group where we would meet once a week for 4 hours each week, simply to code video.
So cool.
And so after years of coding video with Lee, it's now an integral part of my life and the training that I do with my students.
Yeah, so before we start recording, we're saying how geeky we are and how much we love this kind of stuff.
Right.
I think it's good to tell people that Lee was an amazing researcher. The model is based on research a lot.
Absolutely. And she really was focused on taking the findings from research and integrating it into the model. And so the model is very flexible, meaning that she built it so that it can grow.
Mm-hmm.
And so as we learn more through research, it's very easy to add it to the model. And it's kind of like a working live model as a result.
It's very cool.
I love it when I go to a conference and I discover some new findings. And then I just have to kind of sit in front of the model and be like, okay, where do we put it?
Where does it fit?
Yeah, where does this fit? Yeah.
So it's called affect phobia therapy. I'm going to have to ask that typical question. How do you define an affect phobia?
Oh, great question. I mean, we define it as like an emotion that someone has a phobic response toward. So in the face of either experiencing that emotion or being with someone who's experiencing the emotion or expressing it, a person, instead of allowing themselves to feel the emotion and to allow it to impact them, will instead pull back with different types of anxiety.
Mm-hmm.
And so we call it inhibitory affects, and that would be like anxiety, guilt, shame, disgust, and emotional pain.
Mm-hmm.
And when someone pulls back from an emotion with the inhibitory affects, at a certain point it can become too uncomfortable for them, and then it'll pull into a maladaptive defense. Mm-hmm. And at that point, the emotion is completely blocked off, and so the person's not able to connect with it at all. So we use exposure and desensitization to help people be able to become comfortable with an emotion that they've developed an affect phobia toward.
Now, this is the part that's so cool about the model, because it takes an idea from behavior therapy, in a way, desensitization, into a psychodynamic framework.
Absolutely. Uh-huh. And what I really loved about Lee the most is she was a behavioralist first. And so, for her, when she was working with people who were phobic to an emotion, she was really picking up on the behavioral clues that would tell her that was the case.
Uh-huh.
And so she had like this fabulous eye for being able to read people's facial expressions, to pay attention to their nonverbal expressions, and to work from that place.
I've been incredibly surprised with the experiential and the short-term dynamic tradition of how good they are at watching process, the moment-by-moment stuff. It's amazing to me.
Absolutely. And, I really enjoyed watching one of your interviews with Rhonda Goldman
Hmm.
because I thought she did an excellent job of describing that moment to moment process.
Yeah.
And, I'm always amazed by my colleagues with how well they do it. And because we tend to do a lot of research groups in the APT tradition, we have the opportunity to watch our colleagues watch videotape,
Hmm.
code it, and then discuss what they were seeing. And what happens every single time is everyone sees something different.
Yeah.
And it's really taught me that I can know what I know, but there's so much more to understand. And
Hmm.
so out of practicing research, it's taught me to be very open-minded and curious about, okay, what did I miss and what did someone else catch?
Sounds
And
very healthy. Yeah.
collaborate together. Yeah.
Uh-huh.
Yeah.
How do you distinguish between an affect phobia and just normal adaptive inhibition or down-regulating of emotion that sometimes could be helpful?
Oh, that's a wonderful question. Nobody's ever asked me that question before.
Good, a new one.
Yeah, yeah. I mean, I think one thing to pay attention to is connection and how able is someone to be connected with themselves and connected with another person. So if someone's having, if they're pulling back from an emotion, and it's a very healthy process for them, they're still going to be able to be connected with themselves and with others.
Yeah.
But if they're pulling back to the point that like a defense comes in, then it becomes impossible for them to have that connection internally and that connection with others.
Yeah.
And so that's definitely one thing that I pay attention to is someone can be pulling back from an emotion, but are they able to be in connection with themselves or in connection with me?
Uh-huh.
And then another thing is like, does it hurt? Is them pulling back from an emotion creating problems in their life and creating suffering for them?
You mean a chronic way?
Yeah,
Mhm.
yeah. So, defenses can be very healthy for human beings, and we use them every single day in a healthy way.
Mhm.
But they're like a resource for us, and they help us like grow and become, our full selves. But if defenses are, in charge of us versus, then things can really go haywire,
Yeah.
and suddenly they can create a lot of problems for a person.
Yeah.
So I think one thing that we look at is flexibility. Like, how flexible can someone be, and do they ultimately have control over their inhibitory affects and defenses? Like, can they be in charge
Mhm.
of using them or not on some level?
Uh-huh.
A lot of people who come in for treatment, that's not the case. Their anxiety is in charge of their life,
Mhm.
right? And as well as all the defenses that are familiar to them. So we try to turn that around and help people be more in charge of their anxiety and to choose whether or not they're going to use a defense versus it automatically happening.
Yeah, makes a lot of sense to me. And I know that, when I read your books, there's also this emphasis that I personally always like, which is also a developmental focus in a way. Like,
Oh,
how
yeah.
does this come from? How can... And I would like to give you this question in a way that, how do you think an affect phobia develops over time? I know I'm sure that there are many different ways, but a brief overview, maybe.
Yeah, there's many different ways, as you know, and if we look at someone's attachment development, I mean, a lot of times that's where we can find an affect phobia is, how comfortable were their parents with emotion or their culture with emotion, and one thing that I see when I'm traveling around the world is that different cultures have specific affect phobias that they hold close to their heart.
Can you give us an example?
Uh, Absolutely. Like, when I'm in Amsterdam teaching, that's the first place that I taught in 2008. It didn't take me long to discover that the Dutch can be very harsh with themselves.
Uh-huh.
There's like a real perfectionistic flavor to the culture. And so they put a lot of pressure on themselves and can be very critical. And of course, that'll pull over to other people too.
Yeah.
Because you're critical with yourself, you're
Uh-huh.
bound to be be critical with another. So when I'm in Amsterdam, I tend to do a lot of compassion work and, helping the clinicians be able to see how they are being critical and judgmental with themselves, and
More
how
so than in other cultures, you feel?
what's that?
You find that more so than in other cultures, you feel?
Yeah, I definitely
Wow.
see more of that. And then there's some cultures where there's a significant block to anger assertion.
Mm-hmm.
And believe it or not, people think that Americans don't have that, right? I discover it's very much a part of our culture because, Americans will gravitate to maladaptive anger, but not necessarily the, healthy adaptive anger where they can feel it inside their body and then choose how to respond to certain situations, because that entails a lot of internal focus and control. And so a lot of times when I'm working with Americans, it's like the question is how can we become less superficial and we can become more attuned to what's happening inside of ourselves. And but the self-critical piece, I mean, I see that everywhere. It's just that the Dutch seem to have it, really well.
They're training at that for years.
Yeah, and the Swedes definitely have that too, and also Norwegians, and of course, I spent a lot of time in Ireland, and I see it there as well. But in Ireland, there's so many affect phobias. It's almost like all of them kind of, are specialty for the Irish.
And you were talking about culture, and you talked about the upbringing. I know that you're also doing some workshops on transgenerational affect phobia.
Yeah. That's my specialty and my love, because I came into APT as a child, adolescent, family therapist. And so for me, I had the opportunity to see, young children with affect phobias and how they learned them from their family system or their culture. And it's a real art form to be able to work with the child and help them move through an affect phobia, because you also have to work with the family too, and get the parents involved so that they can address their own affect phobias and see how it impacts their children, and then be able to work with themselves and their children. So the transgenerational affect phobia workshop really talks about looking at the whole family system and paying attention to the influence of the parents with affect phobias. But always in affect phobia, we pay attention to where did the affect phobia originate from, what age.
Okay.
There's one book that I think is just so lovely. It's called The Boy Who Was Raised as a Dog.
I don't know it.
Yeah, and it's a great book written by a child psychiatrist and his work working with traumatized children.
Okay.
And it's the easiest book to read to look at developmental trauma and to see how to resolve it.
Wow.
And that's a lot of what we do in affect phobia therapy. It's not just, you have a block to anger assertion, but it's where did that originate from and how did it play out in your childhood?
Yeah.
And in some cases, someone might have a story, like a traumatic story with the parent that we can hyper focus in on and try to restructure the affect, meaning if that's where the affect phobia originated from, we focus in on that trauma with the specific person and try to help someone actually be able to experience their emotion and express it.
Yeah.
Just being stuck in time. So.
And this connects a little bit to me again to the desensitization idea, because it seems to be an inherently relational work, in the sense that you have to use, for instance, if the person is ashamed of something, you use yourself as a therapist as a vehicle to unshame the other person.
Right. That's something that is a really important aspect of our work. And, in APT, the therapists are trained to be collaborators. And so they're very much working with their client. It's a project two of them are working on together. And one thing that can happen is therapists can feel like, well, if I just shower someone with self-compassion, then that's going to create change in of itself. And we really teach our therapists to be able to kind of take a step backward and to be able to assess where a person is and what they can possibly be able to experience in the moment. Because of the exposure and desensitization, we work step by step, and we expose people to an experience that they can actually take in. And then when it becomes too much, we pull back, and then we go back to the exposure again.
Like good behavior therapy.
Absolutely, absolutely. And so, when you were paying attention to when we're looking at videos and doing like consultations, it's all about like, well, where's your client? And can you meet them where they are? And then can you do a little exposure, just as much as they can bear, and then come back and then go back to it. And so, with compassion, we even teach our therapists that, it's always important to be compassionate, to be mindful of what someone's experiencing. But the ultimate goal is to teach a person how to be compassionate about themselves. And usually the way through that is awareness. Can you help your client increase their awareness of their lack of compassion? And can you help them see how they're pulling back from compassion, what defenses that they're using to block compassion? And can you help them look at whether or not there's motivation to create change? So it's all about really paying attention to the client and seeing if they are interested in increasing their motivational system to let go of defenses and anxiety with compassion, and to move toward a more compassionate way of being.
And how explicit is this work? Do you actually talk a lot with the client about, have you noticed this defense? Have you noticed this creates that?
It's very explicit. It's like the process is transparent. There are times when it may not be in the best interest for the patient to be overly transparent, right? That sometimes you need to do a little bit of work in order for them to get to the place that they can really hold that. But for the most part, we have our patients really engaged in their own therapy. And so we do something called core conflict formulation with patients, so that they can understand what emotions they have access to, what emotions they're blocked to, how to pull back from emotion, what defenses that they use. And we set goals with them in terms of, do they want to resolve it, right? And if so, what are the steps to resolving it? So in an ideal case, clients always know these are my blocks toward what specific emotions, and this is what I need to do in order to work through that.
It's very empowering in a way, giving this knowledge.
It's incredibly empowering. And I always keep in mind with each session that it might be the last session, right? And so can my client have a good experience, but also can they be aware of what they need to work through? So if I never see them again, right, they have like a portfolio that they can flip through in terms of like, how do I take care of myself? So
another thing that in your own model, and I also notice in other models like intensive short-term dynamic therapy, you're very good at assessing anxiety regulation on part of the client. And you were telling like sometimes you try to access more emotions, sometimes it's too much, you go back. When you were talking about this, it reminded me, maybe you could talk just a little bit about this importance of checking out the anxiety and the regulation of the anxiety.
Yeah, I mean, there's been times where I feel like it's ultimately all about the anxiety. That
it's very existentialist in a way. So.
Yeah, and if a person is able to be able to see inside of themselves how much anxiety they're experiencing, if they can actually label it, if they could say, well, I have a 7 out of 10 of anxiety right now, then it can really help them begin to manage their anxiety in a way that can be really useful. And so, we very much are paying attention to anxiety. As a clinician, I'm always watching for signs of anxiety,
Yeah.
right? Because that tells me if I need to regulate anxiety or if I need to explore anxiety. Because sometimes if the anxiety is getting too high, it'll move to a defense and then that blocks access to emotion.
Yeah.
So I might need to just help someone regulate their anxiety.
Mhm.
But other times, there's always a rise in anxiety before someone has an affect exposure too. So it's you have to really know, when anxiety's too high or when it's just in that rise where it can be an opening to affect.
Yeah. Because zero anxiety is also a sign of not engagement in a way.
Yeah, it's sort of like there's lack of engagement or, or someone's cut off.
Okay.
And we have found through research that there's always like a rise of anxiety and then it gateways into an affect exposure. And so, but in the same breath, there could be a rise of anxiety and it gets higher and higher, and then you're in a defense, and then there's no affect exposure occurring.
Yeah.
So it's interesting because as a therapist, you have to have a real eye for anxiety, and you have to be flexible with knowing, like, well, maybe I can explore anxiety right now and a gateway to affect. Or, oh, maybe I need to start regulating so they don't get defended in session and possibly get stuck for the rest of the session.
It's interesting because I know you're going this year to the CEPI conference and you're going to talk about clinical decision making. Now I can understand part of what guides you throughout the session.
Yeah, and that comes all from coding videotape. We use a scale that Lee developed called the ATOS scale, and it helps you look at patients and whether or not they're aware of their defenses, whether or not they have motivation for change, if they've had an affect exposure, how much inhibitory affect are they experiencing in session. And when we code, it's only about what's happening in the moment of the session. And so we're really trained to very much pay attention to anxiety, and defenses, and then affect exposures. And it's the coding as a part of the training. So,
Now that you mentioned the ATOS, I know Lee, she must have watched thousands of tapes during her lifetime. Yeah. You must be also trying to break some record, I can imagine.
Yeah, today I was like, could I say 1,000? I don't know.
You hope.
Years.
And when you watched the tape, going back a little just out of my curiosity, when you did supervision with Lee and you showed her a tape, what would she be looking for? Do you remember?
Oh, well, yeah, great question. Lee was I have to have a moment here. She was a person who was always learning. So she would always had like a new obsession that she would focus in on. And that always influenced the supervision because, I'll never forget when she really understood compassion and its importance to the work. It was suddenly, that's all she was looking for, right?
So she shifted a lot in a way.
Yeah. But back in the days, the main focus was affect exposure. And at that time, we used to think more about affect as a single affect. These days, I think we think more of multiple affects, meaning if somebody access like anger, we can expect that they're probably going to access grief, that there might be some guilt, right? That there might be some positive feelings. Like it's almost like we understand that affect travels in packs. Dolphins, right? You always see dolphins together, right? And back in those days, we were just more focused on the single affect. So Lee would be focused on, did you get the anger exposure?
Okay.
Right. And okay, what do you have to do? You need to regulate the anxiety. You need to block the defense to get to the anger exposure. And things have loosened up a little bit since then. But when I would be working with her, it was all about, you missed your opening and you need regulating, and you'd have to start working with defenses.
Yeah.
And what's fascinating is because we worked in a group, I really learned that therapists tend to have, they tend to be really good on one corner of the triangle, because we use the triangles to differentiate everything. And so they're either really good with anxiety, they're really good with defenses, or they're really good with affect exposures. And I came from like more of an experiential background, and I was also a child adolescent therapist. So I was very comfortable with affect exposures. It was almost like that was easy for me. Regulating anxiety, I couldn't even see it in the beginning. I just, it was, I was so comfortable with affect that I didn't really have an eye for it. And so over the years, I've had to really train myself to become better at seeing anxiety, and then also knowing how to respond depending on how much anxiety is a person's experiencing.
Now I have to make a bridge, because you talked about you coded with the ATOS, a measure that she created, and you developed ATOS for therapists.
Yes, yeah.
So this shift, let me try to segue into this question, this idea that what about the affect phobia of the therapist? How does that show up in the therapy room?
Yeah, well, that's a part of the ATOS therapist piece. So let me just tell you how the ATOS therapist happened, and then we can move to the affect phobia of the therapist, because this is really what I'm very much
into.
Yeah, extremely. And it's been years at this point. I don't think it's going away. But, for me as a clinician, to have the opportunity to be working with a researcher and a clinician was a unique opportunity, because, I would be watching Lee's video and we would be coding it. And as a researcher, she would hyper-focus on what to pay attention to, depending on what we were researching at that time. And, there's a huge emphasis on patient and patient outcome in the field. And so we were always looking at, did the client experience this affect? And so the focus was always on the client. And I would always be noticing, well, what Lee was doing. I mean, and how what she was doing was influencing the client in a profound way, but we weren't talking about it. Right? We were just talking about the patient. And one thing that's interesting about Lee is that she had some innate ability to relate with others. And so she was non-verbally saying a lot more than she was saying verbally. And I was noticing how her non-verbals were influencing the client. But every time I tried to talk about it, there was absolutely no interest on Lee's end with talking about herself or what she was doing. It was all about the client. So we went to see Alan Abbas up in Halifax, Nova Scotia in 2009. And he's also a researcher clinician like Lee. And I had the same experience watching his video, because all he wanted to talk about was the model, right? If patient was doing, and I was like, well, what about you? Because when you're non-verbally agreeing with the client, I'm noticing that the client really opens up, and so I felt like we were just missing like one of the most important aspects of how psychotherapy works, by just being focused on the patient, not the therapist. And so on that trip, Lee and I actually didn't catch our flight from Halifax to Boston, and we ended up renting a car, and we had to drive like 25 hours. I can't remember how long. It was many, many hours, and we had to get a hotel on the way home. But I had the opportunity to really express to her how frustrated I was that we were always paying attention to the client and that there was this missing piece. And because we had all that time alone in a car, right? We were really able to discuss it, and out of that, I came up with the ATOS therapist. And I remember getting home, and you can relate to this, and just really dumping all the ideas,
Yeah.
onto my computer and then shipping it the next day, right?
Yeah.
And just saying, this is ATOS therapist.
Great.
And so that's how that happened. And it really gave me permission to just openly start paying as much attention to the therapist as the client,
You
which
came
is
out.
profoundly relieving. Yeah.
And what did you start noticing when you started working specifically at the therapist? The differences between therapists, what influenced more?
Yeah, well, this is where we get into the therapist affect phobias. Is I've certainly started noticing when therapists were having phobic reactions to emotion.
Mm.
And unfortunately, you see a lot of that in the APA videos,
Mm.
is that, as you're watching the videos, a client will be very open to experiencing sadness, and the therapist will begin to regulate backward, right?
Can you walk us through? Imagine we're watching. Yeah, I'm really curious. How do you see that? So you're watching the video, the client expresses sadness, for instance. How would you code a therapist backing away from that?
Well, the best way is watching the nonverbals of the therapist.
Mm-hmm.
And so you can very much see a therapist experience anxiety in session.
Uh-huh.
And, it might not be as obvious as the client, but it could be something as simple as they pull back their shoulders, just like I did right there.
Uh-huh.
Or the client brings up an emotion and the therapist goes, right?
Uh-huh.
And it's like they completely block it.
It cuts off.
Yeah, and you have to remember, like, when you really obsess with defenses, right? When someone is experiencing defenses in the face of emotion, they're cut off emotionally with themselves,
Mm-hmm.
but also with other people too.
They don't
And it happens
connect. Yeah.
to therapists too. So, and I see this over and over and over again, therapists changing subjects,
Okay.
therapists actually not hearing what a client's saying,
Uh-huh.
therapists visibly using their body to kind of block a conversation.
Mm-hmm.
And sadly, it's like the therapists have as many anxiety and defenses.
Well, Kristin, I have a research question about this.
Yeah.
Because I've always had a very hard time distinguishing between, when we talk about these nonverbals, like the person goes back and forth or moves the hair or whatever, if it's just like a behavior tic, just a behavior something, or actual symptom of something. Do you understand the question?
Yeah, I do. It's so funny because I never think that way, right?
So imagine someone starts scratching at their nose and you tell it's the polyvogal fury, blah, blah, blah. Or is his nose itchy?
So no, of course it can just be like that. But this is what you pay attention to is impact.
Mm-hmm.
It's always about impact. So if a client is saying, I'm feeling sad, and the therapist starts going like this, right, you just wait to see what happens next.
Okay.
So if the therapist says, oh, that's just so wonderful that you're able to be aware of the sadness that you're experiencing in your body, they're being responsive to the client, right? So it's the impact is happening. It's sort of like a circle. Client says this, therapist says this, the circle continues.
Mm-hmm.
If the therapist is like this, and then their eyes avert and they say nothing, right?
Yeah.
Or they change the subject, you most likely have an affect phobia.
Great. Yeah.
In the room. Yeah.
Well,
And or the therapist hasn't been trained to pay attention.
Yeah.
To the emotion.
Yeah.
But in my world, I watch a lot of emotion-focused videos. So just know how to do it. Yeah.
In your tribe, people already catch on to this.
Yeah. And it's really helped me understand a lot of things. First of all, like therapist anxiety, I think that's probably the biggest problem all of us have, is getting really, really anxious about, did I do that right?
Yeah.
Or what do I do now? Or I'm not sure what to do. It's like we put so much pressure on ourselves to be like masters.
Yeah.
And sometimes just that pressure can create an anxious environment inside of us.
Mm-hmm.
And then if we're too anxious, we're missing potential clues.
Mm-hmm.
And so it may not be like a therapist-affect phobia. Like the therapist just might be feeling too much anxiety inside of themselves,
Yeah.
and that's preventing them from being really open and receiving. And I find that happens more often than not. I'm always kind of working with therapists
Yeah.
and helping them be aware of how anxious they are in their body and whether or not they're putting too much pressure for perfection.
Yeah.
But sometimes with therapists, it's a classic psychodynamic conflict. It's, something happened to them back when,
Mm-hmm.
and they just haven't worked through that conflict,
Yeah.
and it comes out in their work.
Yeah.
And so
I remember. I'm sorry, but I kind of remember popped up when you were saying, because I remember when Lee once wrote in an article that although videotaping sessions was a remarkable tool for learning, how agonizingly painful it was for all of us.
Oh yeah, yeah, absolutely,
Uh-huh.
yeah.
Can you talk a little bit about how the tool of videotape was so important, of course as a researcher, but as a clinician, to work on countertransference, to learn about yourself?
Yeah, it's like everything. I mean, in my world, if you don't videotape, we really don't know what you're doing, right?
I love this. Yeah.
Yeah, so it's sort of like I don't care like how accomplished someone is, how many books they've published. It's all about the videotape in my world, and it's about how you can face emotion and help people be able to become more aware of themselves and experience emotion.
Mm-hmm.
But, videotaping, it's a very hard thing to do, and it really forces a therapist to take themselves seriously, right?
Mm-hmm.
And to learn how to like build up a support system.
Mm-hmm.
And in some cases, to also be able to start working with your own self and conflicts that might exist from childhood, because everything shows up in the videotape, and there's like no running away from the truth.
Uh-huh.
And I think ultimately, like what we do is we help people become emotionally honest with themselves. And when a therapist is recording sessions and looking at sessions with a supervisor or a peer supervision group, they're also facing their own emotional honesty. Like, what really happened in the session?
Uh-huh.
And did it really play out the way you think it did? Or not? And if there's one thing that I've learned is that, objectivity is a very difficult task to truly obtain, that we all have subjective experience. And what we imagine or what we think happens isn't necessarily the case.
Sure.
And so video definitely helps shine, a lot of honesty on the act of psychotherapy.
So I guess you would recommend people to do it.
I strongly recommend that people do it. And it can be frightening at first and very hard, but the act of doing it really helps a therapist strengthen their sense of self. Mm-hmm. And their relationship with others. Mm-hmm. And, I've always felt like I would never want to work with a therapist for myself that was a follower, right? I want to work with someone who's strong and has like really good critical thinking skills and who has, their own emotional honesty. And in some way, videotaping our work kind of forces us to really look at ourselves and figure out, well, what do I need to learn differently, and what do I need to adjust? And, one of the biggest problems that I see therapists having, and it's true for myself too, is overworking, being overly involved. Like it's having like our needs create pressure on the patient. Mm-hmm. And one thing that videotaping does is it really shines light if that's happening. And then the therapist has to learn, well, how do I stay contained and respectful mindful that this is another human being's process, and I'm facilitate change, but I'm not there to make it happen, right? That's up to the other person.
It's a hard pill to swallow in a way.
Yeah, very hard. Very hard.
As in good desensitization, do you feel it gets better with time watching yourself on tape?
Oh, yes and no.
Good. If it gets too comfortable, it's bad.
Yeah. It's I mean, unfortunately, you do get it. It can become almost like too easy in a way. Like, for instance, when I first was showing my tape, my heart would be thudding, I would be sweating, I would probably have a breakdown after showing the tape, maybe before, right? And that doesn't happen so much anymore. And so there is a desensitization that occurs. But it is always hard to pay attention to watching yourself and how you may or may not respond with a client. And then also having the courage to face the fact that, well, I have to work on this. And I mean, I've been doing psychotherapy since like 1995, so it's been a long time. And I still am finding things that I need to work on and that I need to really focus in on practicing. And one of the great things about videotaping is that it really forces a therapist to understand how important practice is. And that in a lot of ways, we're no different than a musician or an athlete, that we have to identify, like, what are our strengths, what are our weaknesses, and the areas where we're weak, we need a hyper focus and practice so that we can become balanced and really able to be flexible and creative in sessions. And so video does that.
This theme of deliberate practice is starting to show up in the psychotherapy literature. It's very interesting.
Yeah, very much so. And, and that's just been a part of my life, always. Right. But it's great that we're talking about it and discussing it because, ultimately we're all learning new skills when we're doing psychotherapy, and it requires an enormous amount of dedication and practice. And if you don't do it, the video will show. Right?
You can't fool the video.
You can't fool the video, and
Damn it.
and you can't fool the coding either, because it's not just watching the video in APT. It's we code the video, right? And so how many times I've thought something was fabulous, and then I coded, and I'm like, oh.
Don't you have like a conflict? Like, no, the measure is wrong.
Right.
Well, I don't want to not talk about your new book, Paraverbal Communication in Psychotherapy. First question, how did this book come along?
Yeah, well, when I was talking about, watching Lee not pay attention to herself in her research group, and then going up to see Alan Abbas and seeing the same dynamic with him, I mean, that really was the inspiration of the book. It's like my opportunity to witness these brilliant, like, psychologists, researchers, and be a part of their process. Inspired the book, essentially, because once ATOS Therapist was developed and we started using it, then we were really allowed to very much pay attention to the nonverbal interplay between the therapist and the patient. Because originally it was just the patient, what was happening with the patient. With the ATOS Therapist, now we can look at, well, what is the therapist doing? And how is the patient responding?
And see how they influence each other, right?
Yeah, and vice versa. So in a lot of ways, like when I look at videotape, it's not like one person's more important than the other. It's like they're both important, and it's like, well, how are they playing this out between one another? And there's this fabulous study, I can't remember the name of it right now, but they observed psychiatrists evaluating depressed patients and trying to determine whether or not the depressed patient was suicidal. And what they found was that the written recommendation that the psychiatrist made was much less revealing than watching the videotape of the psychiatrist's facial expressions and
Wow.
nonverbal responses.
Wow.
And so, that study was also a part of the inspiration for the book, is that there's so much more happening beyond the words.
Yeah.
And
Yeah.
we have to look at the whole picture.
When you say paraverbal communication, can you just try to tell us what exactly are you referring to?
Yeah, so we're really referring to anything but the words. So like, even like you and I, we just laughed together right there, right? And that's like a tremendous like bonding moment, even though we're using Skype at the moment, right? And if we were to videotape, and you probably can look at this afterwards,
we can cut the interview now.
Yeah, we could actually study this interview and see what the two of us are doing nonverbally with one another versus just paying attention to the words.
Very cool.
Right, and so that's what the paraverbal piece is just paying attention to everything outside of the words. But it's really about paying attention to the rhythm, and the mirroring, and when people are in sync with one another, and when they're not. Paul Wachtel's APA video is probably the absolute best video to watch to understand this nonverbal interplay. And, Paul really holds himself very professionally when he's working, but a lot comes out with like his how he uses his hands and arms and his face. And you can literally see how it impacts, the patient. And so sometimes even turning off the volume, so you just can watch this like tennis match between people, can be so revealing. But the book, I grew up in the field in research groups. That's how I learned APT, was through a research group. And so, I was trained to do research like at least 4 hours a week. I still do it. And the book basically comes out of the fact that, after ATOS Therapist was made, we really started obsessing about the APA videos. And we looked at a lot of the videos and coded them. It took hours. And unfortunately, we couldn't get permission from the APA to publish our findings.
Very frustrating,
Very frustrating. But fortunately, Paul Wachtel volunteered his APA video, and we were able to use his video in the book. And so I'm ever so grateful to him, and for being so open and giving. And basically the book captures our project of watching APA videos, even though we can't discuss all of them. But then also the ATOS Therapist scale, as well as other scales that we created in the process of this project. And what inspired us was the nonverbal interplay. Like, why aren't we talking about this?
So, of course, the $1 million question is, can you link paraverbal communication to outcomes in therapy?
Yeah, that is the big question.
And
absolutely.
What's your feeling about it?
I mean, I personally think absolutely, right? But we don't really know until we give it a try,
So we have some work to do. Great.
We have a lot of work to do, But isn't that exciting? It's like the world is just open for more exploration.
Well, I think we're kind of finishing up. You were already talking, like, people can check out your trainings because you're now a touring rock star around the world. So it's very easy to catch you. It's very nice. Actually, I have to say, I love the fact that nowadays, for me as a student, it's very easy to catch workshops, a lot easier than it was like 20 years ago. Because my psychotherapy heroes are just catching planes more.
Right,
it's very nice.
Yeah, very nice.
I think one last question that I would like to ask you, that I've been asking all of our colleagues, is what advice would you wish to have received when you were starting out as a psychotherapist?
Oh, wow. That is a great, great question. I have to think about that just a moment.
Go ahead.
'Cause I've never really. I mean, I think it would have been helpful if somebody had told me that the most important thing to do is to always challenge myself,
Mhm.
right? That the moment that I become comfortable is the moment to begin to learn something new,
Mhm.
right? And because, and that goes back to the practice again, is that, you know, we're always learning and always changing. And I've discovered that the the more I learn and change, particularly within, you know, the stronger I become as a therapist.
Uh,
Because it's almost like I have to be really attuned to my clients and the fact that they're arriving to experience change. But the only way that I can stay fresh is by doing it myself too.
mhm. Mhm.
Right? So I think that I would have really appreciated if somebody had told me, just whatever you do, challenge yourself. And when you get comfortable, find a new challenge, you know, because it's like it's stretching the growth process. And I have to tell you, I mean, because of my situation with my mentor, you know, coming down with ALS
Mhm.
and then, you know, tragically dying at an early age, I was just forced into such extreme situations that would require just another interview. That it really stretched me professionally and personally and taught me like what I'm capable of doing. And I think that's had a profound impact in my sessions,
Yeah.
because I can really look at people and see like what's possible. Like even when it's hard, it's
Uh,
possible, right?
it gives you a certain kind of hope in a way.
Oh yeah. Oh
Mhm.
yeah.
Mhm.
And one thing that comforts me these days when I'm working with people is that as hard as it is to experience change, it's doable, right? And anyone can do it,
I guess
right?
that's
But
important, yeah, to know that.
yeah, yeah, it requires a lot of practice and a lot of support and a lot of like hope and trust in yourself.
Uh-huh.
And so, you know, sometimes when I'm doing therapy, I'm just keeping in mind, even if the person across from me is like, nope, I can't do this, I'm done. I'm like, yes, you can.
You are that rock.
Yeah, yeah. It's like that childhood story about the little train who could, right?
Uh-huh.
Yeah, I think I can. I think I can. So,
But you know, looking at your career, I think even though you may not have received that advice explicitly, you followed it really well.
yeah, 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 yeah. Yeah. I think I'm saying it would have been helpful to get a heads up. Because I thought I'd go to graduate school, get a little private practice, and
And
then
that's
I'm
it.
done for my lifetime, right?
Exactly. Super shrink forever, and that's it.
Yeah, yeah.
Kristin, thank you so much for this opportunity. It was great.
Thank you. Thank you. This was lovely, and I really appreciate this. So thank you very much.